Hello, this is Steve Yakubov. I'm speaking today at the Scottsdale Interventional Virtual Forum regarding why I use CoreValve. Here are my disclosures. The three topics I would really like to talk about today are hemodynamics and durability, a review of the bicuspid data regarding the use of CoreValve in those patients, and then talk about implant technique. The implant technique influences our pacemaker rate, which has been more important in patients as we get further into the low-risk bicuspid and the low-risk patient population. First of all is hemodynamics and durability. Hemodynamics and PPM are very related. The patient-prosthesis mismatch occurs when the effective orifice area of the valve, even in a normally functioning bioprosthesis, is too small in relationship to that patient's body size. PPM has been correlated to survival, it's been correlated to quality of life, and it's also been correlated with structural valve deterioration. In fact, PPM, when it occurs and is severe, has an increased mortality risk of 1.2 times, and the structural valve deterioration risk is 2 to 3-fold greater. The clinical impact on the effective orifice area with PPM is profound. Comparing a self-expanding supraannular valve such as CoreValve compared to an intraannular valve such as Sapien, we can see that the occurrences of PPM are always greater with intravalvular designs in small annuli, medium annuli, or even in large annuli. The valve design absolutely drives the hemodynamic performance. In an in vitro model, which isn't affected by pressure recovery, the Evolute valve has improved hemodynamic performance, both measured by Doppler and by catheter-based pressure measurements. At rest, the Doppler measurements are improved by 20 to 25%. By catheter measurements, it's greater than 40% with the supraannular design. Once the stroke volumes increased, mimicking exercise, these differences tend to be quite profound. By Doppler measurement, it exceeds 25% difference between self-expanding supraannular valves compared to intravalvular designs. And by catheter-based measurements, the pressure difference can be greater than 50%. Doppler velocity index may be a better way to assess the performance of the valves. DVI is not as influenced by LVOT measurements. The DVI is really a measurement of obstruction defined by the velocity index in the LVOT compared to the velocity index across the aortic valve. And if we look at patients with small annuli, the low DVI is really exceptional with intraannular valves. Self-expanding supraannular valves tend to produce greater DVI and less patient prosthesis mismatch, especially the smaller the annulus. A DVI of less than 0.5 is correlated to an increased risk of death. So the key points of the hemodynamics is there is a superiority of the hemodynamic performance of supraannular self-expanding valves. The differences in the gradients are accentuated by higher stroke volumes, exercise, and with time. The proportion of patients with smaller annuli and greater than 20 millimeters of mercury are higher with intraannular valve designs. A supraannular design may give better performance in patients with small annuli, and it's especially applicable to those patients needing valve-in-valve procedures. DVI is a better predictor of outcomes than just indexed effective orifice area. And there's a correlation between low DVI, quality of life, and mortality in TAVR and SAVR. These changes in hemodynamics may translate into durability. What we're seeing with the supraannular self-expanding valve is that there doesn't appear to be an increased rate of structural valve deterioration, and even out to 5 years, it looks like the TAVR structural valve deterioration is relatively flat compared to surgical aortic valves. Self-expanding supraannular valves may have an advantage. Next, I'll turn our attention to bicuspid aortic valves. At the recent ACC meeting, data was presented with regards to low-risk bicuspid registry with using the Evolut valve. The insights from the previous STS-TVT registry show that it's reasonable to use transcatheter valve designs in patients with bicuspid valves. It looks like the mortality is comparable to what we would see with 3-leaflet valves, and the incidence of stroke may be slightly greater, but fairly similar to what we see with 3-leaflet valves. The bicuspid patient population has several concerns of significance. There may be a higher incidence of annular rupture, there may be a higher incidence of paravalvular leak, stroke rates might be higher, and perhaps the need for pacemakers may be higher. The procedural characteristics in the registry showed that there are still 63% of patients received general anesthesia, 99% were done through iliofemoral access, embolic protection was used in 30%. The protocol pre-specified that balloon dilatation was done before valve implantation, so 91% of the patients received a pre-BAV. Post-dilatation occurred in 37% of the patients. The greatest number of patients received a 34 millimeter valve, and that was in the low risk bicuspid registry. The results were outstanding. The incidence of all-cause mortality or stroke was 1.3%, non-disabling stroke was 3%. There were no annular ruptures, the pacemaker rate was 15%, and major vascular complications were lower also. The hemodynamic performance in the bicuspid patients was outstanding. Effective orifice areas were greater than 2.3, and pressure measurements were less than 9 millimeters of mercury at 30 days. There was very little moderate or severe paravalvular leak in this registry. And the considerations in bicuspid patients that are important is the pigtail is placed in the lowest part of the bicuspid valve, usually a non-coronary cusp area. Pre-BAV may be more important to allow proper frame expansion. The frame expansion should be confirmed both in the LAO and RAO projections to make sure that this valve is fully dilated. And if it is not fully expanded, post-dilatation should occur with a high-pressure balloon at not greater than the mean diameter of the annulus and not greater than 2 millimeters more than the constrained portion of the valve. This leads us to implant techniques to lower pacemaker rates with CoreValve. The cusp overlap view has been championed by Dr. Hamilgata. This cusp overlap view isolates the non-coronary cusp, usually in the ariocaudal projection. The non-coronary cusp is isolated, the right coronary cusp and the left coronary cusp are overlapped. This is typically in this ariocaudal projection. This allows basal plane alignment of all coronary cusps. It elongates the outflow tract. It usually eliminates the parallax of the valve without having to make further manipulations in the II. And it is the best assessment of the depth of implantation in the non-coronary cusp. The technique starts out in an ariocaudal view most commonly. There is no parallax of the valve, and deployment occurs along that non-coronary cusp. Typically, a double curved Lunderquist wire is the wire of choice. It requires very little contrast injection. As long as you know exactly where the non-coronary cusp is, that is the basis for deployment of the valve. Here is a technique Demonstration: the pigtail is in the non-coronary cusp. As the catheter is being delivered, initial deployment starts above the annular plane. As the catheter is being delivered, it tends to dive down below the annular plane. That depth of deployment can be controlled by gentle manipulation of the catheter, but preferentially manipulation of the wire to allow the valve to be lower or higher along the non-coronary cusp. Once the third node is revealed, pacing often is occurring at 120 to 140 beats a minute. The catheter then is deployed fairly rapidly in a controlled fashion. After the depth of implantation on the non-coronary cusp is assessed, we roll over to the LEO projection to see where we are aligned along the left coronary cusp, and then final deployment occurs at that point in time. Final deployment can occur either in the LEO or REO projection. Angiography is unreliable to assess the implant depth. That is why these techniques of REO and LEO manipulation are better assessments. And we know that single-digit pacemaker rates can be achieved if the valve is deployed in the membranous septum using this technique. The cusp overlap technique will be tested in the Optimized Pro clinical trial. There will be 400 patients with aortic stenosis that will undergo procedures assessing AV conduction disturbances as well as all-cause mortality and stroke. All the patients will have the REO cusp overlap technique used during implantation. The goal is to achieve pacemaker rates that are less than. The purpose of the cusp overlap technique. Thank you for your time and attention.